definition, the most important words are human activity. Due to the human activity, the global composition, in addition to the natural variations that happens, there is an additional artificial change that is added on to this natural change. And that artificial change doesn't conform to the natural timing. When you take the timing of the climate change in the natural sequence, it takes a while, it has its own pattern. But this artificial change due to the human activity is too fast and it is unnatural. And that's what's happening. So if you look at the where all of us are originating from, all the living beings we are impacted by this term called biosphere. Biosphere includes atmosphere that we are very much aware of, hydrosphere, that is the water and the oceans and the river, and lithosphere, and that is the earth. And what we have to appreciate is all these three areas. I want to get rid of this black thing here. All these areas are affected by the changes in the environment. It is not just air pollution. There is water pollution, there is ground pollution, and there's atmospheric pollution. All these things are occurring and affects every type of life. It is not just human beings. It affects all the animals, the fish, all the aquatic animals, the trees, the grass, the weeds, everything is affected by this type of pollution. So if you take the climate change over the past several 10,000 years, you see there are changes that have happened naturally over a period of time. It dates all the way from 16,000 BC. You see the ice age. Then there's a warming, like a warming period, cooler period is happening. And that has got significant intervals between that. But what has happened down the road, the last item you come down, 1870 to 2020. 1870 is the starting of the industrial age. The industrial age, when things started moving very fast due to our activity. And that is since then the global warming has started. It has not started in the last 10 years or 20 years. It has started more than 100 to 200 years ago. I mean, 100 to 150 years ago. But at the rate at which it is progressing is quite alarming. I don't know why this move gives me hard. I'm showing you a picture of the Maasai tribe. Why am I showing you this very nice picture? Myself and Kamala, we visit Kenya often. And during this visit about a few years ago, I was in Masai Mara, which many of you might have gone, most famous forest, reserve in Africa. And I went to a village there, Maasai village, and spent about 4 to 6 hours with the villagers. And the chief's son had good knowledge of English, so he could communicate well. And Kenya was a British colony before, so several people know pretty decent English. We took a tour of the village, tour of the surroundings, even went to their school. And what I found there was the closeness of their living with nature. They live with nature. They don't live against nature. They live with it. The reason why I am saying that is every requirement of the Maasai tribe, whether it is food, medications, or any type of requirements they need in their daily life for their fuel or the house construction material, for their domestic purpose materials, everything is obtained within a radius of 5 miles, including he showed me some trees or some shrubs showing this is the poison tree, which is I use this to kill the elephants or the tigers. I use this. And this is and also showed me another plant says this is the aphrodisiac that some of our older people use. And all these things informed us that These people live with nature, and no wonder they look so healthy and physically, mentally, probably spiritually. Look at our lives here. This is in Delhi, in India, and a few other places. And as you know, if you look at the first 15 most polluted areas in the globe, almost 10 of them happen to be in India as well as in China. And that is because, not just because our um, way of operating, but the way we live. The way we live, we create a lot of garbage, we create a lot of pollution, and our lifestyle is almost against nature. A lot of unnatural things we have. And say, like, you go to the forest is very, very quiet. There are thousands of animals, but it is quiet. Once the man enters in his two-wheeler or four-wheeler or whatever, he creates noise. So there is sound pollution, in the forest, mostly because of human beings, not of any animals. And the same thing happens all over. So what it does over a period of time, it changes the environment. So because of this, all this activity that is going on, human activity, there are several types of chemicals that are emitted. The prominent one is carbon dioxide, ozone, and sour methane, and all those things. We will come to that in a few minutes. The earth is getting warmer, it is getting heated up, and it may look 3 degrees centigrade is not a whole lot, but actually even 1 degree centigrade, which is significant in the earth warming, which has already happened now. And that is why we are seeing so many hot days and warm periods across the globe. So we have atmospheric CO2 that is increasing, acidity of the oceans are increasing, ocean water levels are increasing. We have unexplained, very, very hot days. We don't know why it is so hot. This week is so hot, we say, miserable. So I was just in India a few weeks ago, and as April was coming, I was still there until later part of April. It became so hot. And after I came back to US, I kept on following the weather pattern in India. The temperature in Delhi almost reached 50 degrees centigrade. It almost comes to around 120 degrees Fahrenheit. So these things are happening really. And there are very unusual cold days where it is not supposed to be cold, it will be very cold. Like even in the US, it's happening in southern part of US, Texas, Alabama, all these Florida, where it is supposed to be warm year round, very comfortable. But we have had many cold days. Actually, it even snowed in Texas, and there was ice, and that caused significant issues to the population and to the infrastructure there. And we have heat related deaths. And in addition to all this, what is happening is population migration. Population is shifting from rural areas to urban areas. There's a slide on it I'll show you in a few minutes. This is a very interesting slide. It is a simulation from a setup in Santa Monica, California, where they say, what will it look when the temperature rises, and what will happen to the ocean, and especially the cities along the coast. Houston, a huge metropolis in Texas, is on the ocean. And you see on the left hand side, on the upper hand side, is the Houston Space Center. And when the temperature has risen by 1.5 degrees centigrade, the temperature of the ocean, the water has already entered, and there is no more parking lot. Almost taken over. 50 to 60% of the parking lot is taken over by the rising water. When it rises 3 degrees, the whole thing is taken over. It's almost, the facility is unreachable. And this is what the scenario could be. We are already reaching there up to 1.1, between 1 and 1.5. And the same thing, another scenario in the city of Santa Monica, on the west coast of in the California uh, side. You will see Santa Monica on the left-hand side, the way the city is, the way it could be when the temperature is up at 3 degrees. Practically half of it will be underwater. And this is the population migration. 2018, 58% of the population is urban. 2050, almost 70% will be urban. So urban areas are getting crowded. Urban areas are getting hotter. Urban areas are also getting more allergenic as far as our specialty goes. And 90% of the world's population, these are very disturbing facts, but it is true. 90% of the world population live in areas with low air quality. This is according to WHO. COPD and IHB are definitely, so it is not just the lungs that are bothered. Ischemic heart disease are also causing significant issues, and they're one of the leading causes of death due to air pollution. And air pollution or pollution per se affects every organ in the system. It affects even from womb all the way to the tomb. So the effects start even during pregnancy. The fetus is already getting affected, and there is significant evidence to show the presence of chemicals. Several noxious chemicals have been demonstrated and shown to be in the amniotic fluid in the highly polluted areas. And these are all more disturbing facts, that there's a significant amount of morbidity and mortality because of this pollution. And according to the WHO Director General, she says that evidence is overwhelming. Climate change endangers human health, and solutions do exist, but we need to act. We need to act. But are we really acting that fast? Answer is no. We are not acting that fast. So I want to just share this video if it comes on. Let me see if it comes on. No, yes. Let us look at this video.
Air pollution consists of chemicals or particles in the atmosphere that pose serious health and environmental threats. But what causes air pollution, and what does it mean for our planet? Some air pollution comes from natural sources like volcanic eruptions, wildfires, or allergens. But most air pollution results from human activities, such as energy use and agriculture. There are different types of human-made air pollution. When we burn fossil fuels to produce energy, they release greenhouse gases into the air. These emissions, such as carbon dioxide, methane, nitrous oxide, and fluorinated gases, trap heat from the sun in Earth's atmosphere, leading to a rise in global temperatures. This creates a cycle where air pollution contributes to climate change, and climate change creates higher temperatures. In turn, higher temperatures intensify some types of air pollution. For example, climate change increases smog because it forms in the presence of high heat and increased levels of ultraviolet radiation. More frequent extreme weather, such as flooding, contributes to damp conditions and therefore to a rise in mold. Warmer weather also leads to longer pollen seasons and therefore more pollen production. Smog is a type of air pollution that reduces visibility and has serious health effects. Smog can be divided into two categories: sulfurous and photochemical. Sulfurous smog is made up of chemical compounds called sulfur oxides. It occurs when burning sulfur-bearing fossil fuels such as coal. Photochemical smog, also called ground-level ozone, is a result of the reaction between sunlight, nitrogen oxides, and volatile organic compounds. Nitrogen oxides come from car exhaust, coal power plants, and factory emissions. Volatile organic compounds are released from gasoline, paints, and many cleaning solvents. Smog not only creates a brown haze that reduces visibility, but also harms plants, irritates the eyes, and causes respiratory distress. Another category of air pollution is toxic pollutants. These are chemicals such as mercury, lead, dioxins, and benzene that are released during gas or coal combustion, waste incineration, or burning of gasoline. In addition to adverse environmental effects, toxic air pollution can cause serious health problems such as cancer, reproductive complications, and birth defects. While air pollution has many consequences for our planet, there are solutions. We can limit toxic pollutants, smog, and greenhouse gases by decreasing the use of fossil fuels, such as in transportation, manufacturing, and electricity generation. Reducing air pollution not only contributes to a cleaner environment and better human health, but can also slow the rate of global warming.
Okay, thank you. Let's move on. That gave you a pretty good picture of what air pollution can do. Now, this slide is showing you the relationship between the drivers of the climate change, and what is the outcome. And the things that the film showed you already: industries, electricity, heat production, buildings, transportation, construction, agriculture, all the things that are surrounding us every day, 24/7, 365, transportation is causing these changes, and that is producing these outcomes of the climate change is the forest fires, storms, ground level ozone, and causing these greenhouse gas effect, and all these changes. That it's a vicious cycle that keeps on going. And what are the risk factors? Who are affected more? The people it's affected all of us, but there are certain uh, categories of the population that are affected more than others, especially the pollution that is produced in the developed countries actually affects people in the developing countries or low middle income countries much more, because it travels quite a bit. Air pollution travels thousands of miles across the globe. And the people who are affected more are the people who are socioeconomically compromised in the lower middle income countries, elderly people, children, because children are active physically, they are more outdoors, they breathe in a lot more of these pollutants and they are affected, and indigenous people who have nothing to do with causing any of these effects, but they are also affected. Pregnant ladies, minorities, migrants, and people with comorbid conditions, people with asthma, COPD, other pulmonary conditions, cardiac conditions, immunodeficiencies. These are all significant risk factors for effects of pollution. And there is a term called exposome and endosome. The internal exposome and external exposome. What is external exposome? Is all these factors, all the exposures of an individual in a lifetime, how these exposures relate to health. This is like a concept overview. And if you look at basically specifically allergic diseases and the involved organs, you find that all the allergic diseases are affected by these pollutants. Eczema, urticaria, allergic rhinitis, asthma, food allergy, drug allergy, anaphylactic, all the allergic diseases are affected by these pollutants. Another thing that is happening is these pollutants can cause what we call as epigenetic changes, occurs at the molecular level. And when you get epigenetic changes, because of the change that is happening in the configuration of the amino acids, not the actual gene structure, the the tendency to develop these diseases will be much more, and also these epigenetic changes can be transmitted for the next 2 generations. So whatever we are doing now, it could not only affect us, but it could also affect our offsprings. Our unborn children also could be affected because of these epigenetic changes being transmitted across generations, at least for next 2 generations. And if there are some of the things that we need to know as pediatricians and allergists and general doctors, that we see these, we think it's all due to breathing that pollution is affected, but actually air pollution affects the skin. It actually increases the susceptibility to atopic dermatitis. Air pollution makes your skin more susceptible to atopic dermatitis, as well as it increases the severity of the atopic dermatitis. In allergic people, the epithelium is already compromised. There is a significant um, entry of several noxious agents, aeroallergens, chemicals, and foods through the skin, and actually pollutants facilitates the entry of these allergens, and in turn hastens the allergic march. It hastens the development of asthma from allergic rhinitis, development of asthma from atopic dermatitis, hastens the development of food allergies. So this is something we need to be aware of, that air pollution can affect the skin in an adverse way, especially in the hastening the allergic march. And other mechanisms are, in not only damaging the epithelial integrity, it can also cause a release of the cytokines, chemokine release. And I already have mentioned epigenetic changes, endotoxin productions, irritant mechanisms. And the other important thing is increased susceptibility to viral infections. So if you are living in a polluted area, your susceptibility to viral infections is more. You get more viral infections. And that in turn cause more airway inflammation. And we already know allergic diseases and viral diseases are sort of interconnected. They work in unison. So if you have more viral infections, chances are you will have more allergic symptoms, problems because of inflammation. And when you have more allergies, you have more viral infections. And pollutant is sort of an intermediary here. So this is like a diagrammatic fashion showing you what I just have mentioned in the last 5-10 minutes, that several of these agents, seasonal meteorological agents, traffic-related pollution, industry-related pollution, UV-induced pollution, reactions, all these things produce these chemicals that enters through the skin, enters through the lungs, and cause these different effects. And if you look at what we call as a greenhouse gas effect, the CO2, methane, and the ozone, it is 90% of it is related to human activity, anthropogenic. We are producing we are reason for 90% of this production of these materials. Let me see, I'll move this. 95% of the greenhouse gases is human driven, and it is due to burning of fossil fuels. What happened during these emissions during the pandemic, when we had the COVID pandemic? What happened actually was the emissions fell by 6.4%, but did not cause any major issues. But we could see the air felt cleaner. There was less noise pollution, no planes flying, no unnecessary traffic except emergency, and things were the nature was actually starting to come back. Wild animals were actually moving into towns. So it looked like a lot of positive things were happening during the COVID epidemic environmentally. But once things started coming back towards normal, our emissions started going up, and we are back in the same situation. Nothing permanent has changed. because the effect of this climate change, it has done so much damage. They say it is not going to be reversible completely. Some of it will be permanent. And this is because of many multiple reasons, including, in addition to the carbon footprint being unchanged since 1990, in spite of all the efforts of some countries, there are a lot of other issues, including budgetary issues, and as well as the exposure of these biomass because of population migration. I already have told you. So these things are still continuing. And this telling you that the effects of pollution is significant. Heat waves are another issue that you need to know, that in 2008 in Europe itself, 70,000 people died because of heat waves. And this is occurring in many countries, including India. And this is what's happening. Millions in the Indian northern states sizzle in severe hot heat wave. It is in 2021. Not unusual to have these sites common. And there were 12,500 deaths due to heat waves itself. And as I just told you, the temperature soared to 124 degrees just recently. And if you look at the temperature across the globe, March 24 officially was a record warmest month. For 175 years, they have kept a record. March 2024 was the hottest global month. So should we worry? Yes, definitely we need to worry about it. Now, just a few words about ozone that we are always talking about. There are two types of ozone. There's a ground level ozone called tropospheric ozone, which is not a good one, which is a combination of volatile organic compounds and nitrous oxide, and it is brought on by heat, by warmer temperatures, and sunlight promotes it. And there's another type of ozone, which is actually a good type. It's called stratospheric ozone, which is way up in the atmosphere, which blocks the ultraviolet light. What is happening recent decades is the good ozone, the stratospheric ozone, is decreasing. So we are getting holes in the atmosphere. So that is why the ultraviolet rate is able to easily reach down to onto our ground surface as well as on our skin, causing significant amount of skin issues, including skin cancer. And the ground level ozone, on the other hand, is increasing. So the good ozone in the atmosphere is decreasing. The bad ozone in the ground level is increasing. So ozone is a very powerful oxidant. It causes tissue damage. And when you have acute high levels of ozone, it causes significant medical issues, respiratory, cardiac, and increases hospitalization, emergency room visits. And that is one of the reasons why we are given these weather bulletins when the emissions are high, especially when the ozone level is high, the weather bulletin gives you a warning. And ozone in relationship to allergies, because of the increased temperature, and the ozone actually exacerbates asthma. There is evidence to say that it even causes new asthma, not only exacerbate existing asthma, but causes new asthma and acts as an adjuvant to allergies. That is, if you already are allergic, your symptoms will be much more. As well as if you are prone for allergies, the allergic march is hastened. You develop allergies much faster and much more severe. Increases the ER visits, hospitalizations. And now we have what we call as urban heat islands. Because of the ground is taken over by cement. So when you go to, say, for example, you go to metro areas, or you go to Dubai, everybody likes, oh, look at Dubai, looks so good, looks so unbelievable, look at those buildings. But actually what it is just a huge heat island. Dubai is a huge heat island full of cement, and it keeps all the heat down. There's huge amount of CO2 production. And as far as our specialty goes, urban areas, produces 7 times more pollens than rural areas. We always thought, oh, rural areas, there is more vegetation, there is all these plants and weeds and grow. But actually, what is happening in the urban areas, because of the urban islands, we also try to put different plants and shrubs in the cities, and they actually produce more pollens than the rural areas. And then you have all these forest fires, which causes the main problem with the forest fires is particulate matter. Particulate matter is the main ingredient. 80 to 90% of the wildfires produce huge amounts of particulate matter. And particulate matter is another highly inflammatory particle, which causes significant cardiac issues, ischemic heart disease, and lung issues. And some of the pictures that you see on the slide actually was taken by me from my backyard, in the Rocky Mountain area. And these are the slides that I have taken. These are the pictures, and it's showing you what exactly is happening right around us. And look at this Saharan dust storms. You are quite familiar with it because it affects the Caribbeans. So there is dust storms that is starting in the Sahara Desert and travels thousands of miles. Actually, Sahara Desert, which has got microbes, minerals, are good for forests. It actually promotes growth, promotes greenery, but at the same time, they have so much of particulate matter, cause a significant environmental impact on human health as well as animal health. And this is in your area in the Caribbeans, the Sahara dust and the coral dust, sea fan disease, asthma. There's a fungus called aspergillus. I don't know how to pronounce it, swidei, and African Sahara Desert, which hopefully will be addressed in the panel discussion because you are experts in it and it is affecting in your area. And if you look at air pollution in the Caribbean, yes, there is definite air pollution and definite impact of climate change in the Caribbean, and mostly with the particulate matter, which is increasing, and Sahara Desert has quite a bit in it, and also urbanization of the living condition in the Caribbean has affected all the different islands. I have listed all the impact of climate change and air pollution affecting every area. There are 18 islands, I think. And the effect of cyclones, because the Caribbean, as you are living, I don't have to tell you about your weather pattern. It is very, very dramatic. Suddenly, these hurricanes come on. And what we see, these storms coming in, hurricanes happening, all these changes happening and moving on to the mainland, natural disasters occur much more frequently, costs a lot more to the Caribbean population. About 18% of the gross national product is diminished because of these natural disasters. Since 1950, 324 disasters have taken place in the Caribbean, causing a loss of more than 250,000 lives and affecting 24 million people. This is huge effect. And these are some of the pictures which many of you are very, very familiar due to the hurricanes. And on an average, as I just told you, the storm damage in the Caribbean is 17% of your GDP, 17%. So there's a huge amount of loss because of the changes, and climate change has a lot to do with it. And as I mentioned already, air pollution, since it causes epithelial dysfunction, damages your mucous membrane and skin, your antiviral immunity is diminished, increased susceptibility to viral infection, which in turn could affect your asthma and many other diseases, increased severity of the viral infection. And all these things are could have affected our COVID morbidity and mortality, because the combination of COVID and pollution is not a good one. And this is what's happening in the US. They follow what they call as plant hardiness zone maps. They follow the trees. And what is showing is the tree lining. The trees are moving north, and trees moves wherever there is warmth. So as the warm temperature, the areas of warmth is increasing in the US, the tree line is moving northwards. And areas that were very cool before, very cold, are actually diminishing. and the whole country is getting warmer. For example, myself in Colorado, when I moved about 50 years ago, we never even thought of air conditioning. The whole area was air conditioned. Now every building has air conditioning. I'm talking about residential areas. Now we had to reinstall air conditioning. We never thought about air conditioning because of the warmth. The whole temperature has warmed up. And this is the effect in the lab. What happens when you uh, increase the carbon dioxide levels? What happens in the atmosphere? What happens in the chambers? The ragweed growth grows exponentially increases. And effects of outdoor environment, the pollution, increased temperatures, increased CO2 causes increased ozone, causes increased aeroallergens, as well as increased duration of pollination. So you will see that flowers are appearing earlier in the trees. Pollens are appearing earlier, and they last longer, and they are of different potency, and they are also produced in larger amounts. So if you look at the farming lands, you may notice that it is affecting the farming land. The crops are looking bigger, larger, but the quality of the crops is actually compromised. There is a thing called carbon nitrogen ratio in these agricultural products, and that is affected by pollution. Although the plant may look big, the quality of the plant product is less. And this is an electron microscopy showing how the particles, the particulate matter and the pollens combine together and they float around, and that's what you breathe in. And they go all the way right into your alveoli because they are so small. Anything less than 7 millimeters will micron 7 millimicrons can affect your lungs, and it is only 2.5 millimicrons. And this I have already told you now. And whatever is bad for us may be good for the birds. I'm not too sure, but they have a pretty good meal because they have a lot of ragweeds and weeds, raban, and the flowering pollens and all that. So they seem to be thriving. So another thing that happens is moisture. Moisture plays increased moisture increases everything, increases mold content, increases dust mite content, increases the cockroach population, rodent population, and all these have an adverse effect, as we very well know, on allergies and asthma. And fungi is more abundant with elevated CO2, and this has been shown even on dead material. Even say like dead leaves will also produce CO2, produces molds, and CO2 increases the fungal growth even on the dead leaves. And these are some of the pictures which happened in Bangalore about a year and a half ago, due to flooding. And this was not in low-lying areas. This was not in where poor people were living. These are very, very prosperous people living in high socioeconomic zones. But what had happened is developers who are corrupt will build these houses in flood-prone zone area. And this is the effect. When it rains, the water enters. And there's indoor flooding, and that is how the molds look indoors. And when you see such things, there is a lot of mold indoors, and that causes huge amount of respiratory issues. Effect on insects, because of these changes that mentioned, there is increased mosquitoes, increased vector-borne diseases, and then we start using increased use of mosquito repellents, and that in turn causes more pollution because they have many, many different chemicals in it. So this, as I have posted you a significant global health threat of the 21st century with all the slides I have shown you. I don't want to keep on talking the same thing over and over again. I am sure you know that overall effect of pollution is negative in many different ways. And this is like a pyramidal type of diagram showing you the changes, the disease patterns, the clinical implications. It's a ripple effect of the climate change occurring all around us. And let me just tell you a few words about this particular issue called epidemic thunderstorm asthma. There is a thing called thunderstorm asthma, which can cause significant problems. What happens is this happens typically in summer months. For example, in month of May and June, when the temperature is hot, there's a lot of pollen count, and the hot air moves upwards, and clouds are forming way up there, and the hot air is going up, clouds are coming down, and when the rain comes, these pollens are hygroscopic. They absorb this water. Pollens actually, you do not, if you are looking at the diameter of a pollen, it is almost pretty big. It is large. It is 25 to 60 millimicrons. They don't reach your alveoli. They may reach your lungs, nose and upper airways. They don't go into your lungs. But when the thunderstorm asthma, when it occurs, what happens is these pollens absorb the water and they rupture. And because of the rupture of the pollens, submicronic particles of the pollens, which are only like 1.5 to 2 millimicrons, are produced in billions and affects. And as the rain comes down, there's a huge amount of these submicronic particles of pollens in the air, and you breathe in, and it is like a bronchial inhalation challenge en masse, and thousands of people got affected in one evening, one day, in the city of Melbourne in, I think, something in 1971, when about 10,000 people got affected because of asthma. There were 1,000 hospitalization in one night in Melbourne, and about 10 people died because of this thunderstorm asthma. So when they looked at the mortality and looked at the cases who died, actually these people were not severe asthmatics. They were mild asthmatics who were not taking their regular inhaled medications. And out of 10, about 4 to 6 of them are of Asian origin. So people from Asia, from China, India, and Singapore, and some countries like that are genetically more prone for this problem. And also, thunderstorm asthma can affect mild asthmatics. Thunderstorm asthma can occur people who do not have asthma but just have allergic rhinitis. So we know people with allergic rhinitis have lower airway disease. They are also prone for asthma. So when people have allergic rhinitis alone and they are not being treated with medications like inhaled steroids or what, when they inhaled the submicronic uh, particles of pollens, they also developed significant asthma. And that is thunderstorm asthma. Relatively a new phenomena, but actually a global health problem directly related to climate change. We need to be aware of it. And this occurs during summer months, especially in combination with grass pollen allergy. And the main reason is people just ignore using their simple medicines. And this can be prevented quite well. The way you prevent it is you look at weather forecast, look at that and pay attention and be aware of it. When it says a thunderstorm is coming, please instruct your patients as well, and as well as in the media it should come, that these people who, even though they have mild allergic disease, they should go on inhaled steroids. Even though they have mild asthma, they should start taking their inhaled steroids, because inhaled steroids or even the usage of beta-adrenergic inhalers prior to the exposure to this thunderstorm actually prevents it. So these forecasts and treating prophylactically just 2 days before the thunderstorm coming seems to reduce the emergency visits, hospitalization, and this is something that could be easily prevented. But it does happen. So climate change, if you look at how many doctors know about it, how many physicians are aware of climate change causing so many issues that we just talked about. Actually, if only very few people, only around 30% knew that it was causing health issues. 74% thought, yes, it is due to human activity. 81%, yes, some climate change is happening. But this was based upon 5,600 physicians who were surveyed in US, and about 22% responded, which is pretty good response. I know why that response came, because they also got some goodies. They were given coupons for free hamburgers and all that, and then they responded, and it was published in the JSA in 2016. So what it tells you is health professionals themselves are not too aware of what climate can do to our health and diseases. So now we have specialties like subspecialty of cardiology has already started. It's called climate cardiology. There are already articles coming. There are many articles coming in allergy literature, in pulmonology, and many other diseases could be. And you know this guy, Prince Charles, now is the King Charles. He was a very, very vocal advocate for a long time. When he got this car, Aston Martin car, from his mom as a gift way back, he did not want to use gasoline. He wanted to stay away from fossil driven fossil origin fuel products. So he went, and he was driving this car on wine and cheese. And this is just a summary of vulnerability. Who is vulnerable to all these different impacts? And when you have some time, please look at all these different um, slides, as well as the reference literature. And this is another beautiful slide showing you overview picture, summarizes all the effects in one picture: effect of weather and climate change occurring, affecting both indoor quality of asthmatic patients, effect of fungus. Actually was drawn by one of our PhD students from my hometown, Mysore, and this was published in JSCI in one of the articles. So final recommendation is, we need to be aware, we need to invest, and we need to gradually phase out of this coal-fired power and reduce urban pollution, and change our lifestyle. Instead of using cars everywhere, using two-wheelers and four-wheelers. That is myself, I bike every day. And this is something I enjoy. It's good for our health. And this is what we need to do. And the last thing I want to show you is, there is a yearly report from Lancet, which counts down, it's published every year, and it gives you a wonderful summary of what's happening around the globe. So this particular article is something that I recommend you to read. Thank you very much. I know this was a long talk, but this was an important talk. Thank you for your patience in listening to this.
Thank you, Doctor. Thank you so much for the detailed and the insightful talk on this. I now request Dr. Vinay Mehta, the board certified allergist and immunologist within Allergy and Asthma Association of in Southern California, to talk on the skin and allergy.
Okay. Good morning, everyone.
Good morning.
Let me share my slides. And thank you, PK, for an interesting talk. I'm one of those physicians that don't know much about environment and pollution. So thank you for that, for refreshing my memory.
Thank you. Welcome. Let me mute myself.
So we'll switch gears, and I was tasked to, my charge this morning is to, in 1 hour, give you an overview of different allergic skin disorders that we as allergists frequently encounter. And so as an introduction, we know that the skin is one of the largest immunological organs, and it is affected by both external and internal factors. And skin rashes are very common. Potential causes include infection, drugs, insect bites, insect stings, autoimmune disorders, variety of dermatological disorders, and then of course our field, the allergic disorders. And in our field, I would say that there are three main allergic skin disorders that we commonly see. Number one, atopic dermatitis. So we'll spend a lot of time focused on that. urticaria. Again, there's some challenges there of how to manage urticaria. And then finally, contact dermatitis, which is also fairly common in our specialty. Okay, so we'll begin with the most common, atopic dermatitis. And I'm sure all of you have seen kids with eczema. I show this picture because I think sometimes we're so used to seeing eczema that we kind of become apathetic. But really, I want to share with you that this is a very important disease because this is the first disease in the atopic march. So it's very important when you see someone with eczema, especially a child, you want to be more aggressive. Don't just say, fine, move on, because there's a lot of potential impact you can make in preventing further allergic disorders if you treat the skin aggressively. So what is eczema? What is atopic dermatitis? It's a chronic disease. It's an itchy disease, so it's pruritic. Obviously, you have eczema, and it is often associated with elevated serum Ig levels and either a personal or family history of atopy. Not necessarily eczema, but it could be asthma, allergic rhinitis, food allergy. One of the ways that we define atopic dermatitis is extrinsic, which is the most common form. It is associated with high Ig levels, high blood eosinophil counts. It is associated with positive skin tests. Often occurs in child with atopic background, and often associated with flagrant gene mutations. And then you have intrinsic eczema, where typically Ig levels normal. It's more common in women, more common with contact dermatitis, especially metal, especially nickel. And oftentimes there's an overlap between atopic dermatitis and contact dermatitis. Now, in terms of epidemiology, we know that it occurs frequently in children, but it also affects adults. So I think there's a myth that most children outgrow eczema. That is not necessarily true. So worldwide, about 20% of children have atopic dermatitis, but so do 7% of adults. And obviously, so this disease can persist. Typically, the onset occurs before the age of 1. So vast majorities by age 5, 85%. The later the onset, however, generally the greater the severity and the more persistent the disease. In terms of epidemiology, remember atopic dermatitis often is associated with other atopic conditions, food allergies, asthma, allergic conjunctivitis, allergic rhinitis, allergic contact dermatitis. It is also associated oftentimes with skin infections, especially staph. And because it's a very chronic itchy disease, it often affects the sleep. It often leads to anxiety, depression. So there are many comorbidities associated with atopic dermatitis. It is what we call the first disease in the atopic march. And so this is nicely illustrated in this study. We looked at a cohort of infants aged 3 to 18 months with recent onset of atopic dermatitis. And they followed this cohort for a period of 3 years. And as you can see, most of them, or a high percentage of them, develop other atopic diseases within 3 years. Allergic rhinitis, about a quarter, allergic conjunctivitis, asthma, food allergy, and over a third had more than one atopic conditions. And this is what we call the atopic march. So if you look at eczema here, here's eczema. So the eczema appears early on, and even though as a child grows older, it generally goes down, the incidence. But what you can see here is that children with eczema often go on to develop food allergies, allergic rhinitis, as well as asthma. And it is thought that if you intervene early, if you help restore the normal epidermal barrier, you may help arrest this progression. So very important to recognize atopic dermatitis early, very important to treat atopic dermatitis early. Now, in terms of Caribbeans, unfortunately, there's a lack of Caribbean studies. However, the Latin American AASC phase 3 study did look at the prevalence of atopic dermatitis and found that about 18.2% of infants had atopic dermatitis, 11.3% of children had atopic dermatitis, and about 10.6% of adolescents had atopic dermatitis. So it's, again, a fairly common disease. I'm sure all of you have seen it or have children with atopic dermatitis. And in terms of what drives atopic dermatitis, well, there are three components. One is the epidermal barrier is often disrupted, meaning that the skin is porous. It therefore allows bacteria to penetrate, especially staph. It allows allergens to penetrate into the skin, which causes sensitization. And because there's a defect in the epidermal barrier, the skin is always dry. Skin is always dry, always dry. There's a loss of transepidermal water loss. And the barrier itself is not very effective. And so it often predisposes the child to infections. And so this is one of the major deficits here. And even when there is no active lesion on the skin, the epidermal barrier itself, if you look under a microscope, is not intact. The second component is immunological abnormalities. So most cases of atopic dermatitis it's a Th2 disease. It's driven by Th2 cytokines, especially IL-4, IL-13, associated with high serum IgE. And this causes inflammation, which further disrupts the epidermal barrier. And then you have external factors, which makes the person itch. So dry skin, irritants like soaps, chemicals, detergents, sweat, stress itself can cause itching. And so you have this constant itch-scratch cycle. The more you itch, the more you scratch, the more you scratch, the more you disrupt the epidermal barrier, the worse the eczema gets. So it's a vicious cycle, nonstop. And especially at night, a lot of children especially scratch subconsciously at night, which actually disrupts your sleep. So what are the risk factors for atopic dermatitis? Like most atopic diseases, family history is important. There's odds ratio of having atopic dermatitis increases by at least threefold if both parents have atopy. There are genetic factors like loss of this filaggrin, so loss of function mutation in the filaggrin gene, which causes major impairment of the skin barrier. Also, race plays a role. So it's higher in the Black race, higher in the Asian Pacific race. And in general, if you look at the globe, it is more prevalent in high-income countries. Although this is, with migration and with westernization, this no longer is a strong association. And then you have other factors that may play a role. We don't exactly know, but certainly pollution plays a role, can play a role, tobacco smoke, frequent antibiotic exposure, and urban setting, probably because of the dust mite. So what are the diagnostic features? Well, you have essential features and you have important features. So essential features, the rash has to itch, so there's pruritus, and then you have eczema, and it's an eczema that's recurrent. And there's typically the eczema, there's a certain pattern depending on the age of the child. So the face, neck, extensor surfaces are involved in infants and children. And typically it spares the groin, it spares the axilla. But it is recurrent. So this is not something this is not a one-time disease. The eczema will come and go, and that's the pattern of atopic dermatitis. Important features, so typically early age of onset, as I mentioned, 85% occur before age 5. Usually there's an atopic background, either a personal history or family history, often associated with positive skin tests, elevated IgE, and then dry skin. Dry skin is, again, a sign of disrupted epidermal barrier. Here's the distribution. So typically, as an infant, you get erythematous papules and vesicles. It affects the cheeks, the forehead, the scalp. Okay, so mainly the face. As a child grows older, it can involve more the extensor surfaces. And then in older children, the flexural folds, the neck, upper arms, back, hands, feet, fingers, and toes. So it's important to kind of know the general pattern depending on the age of the child. And of course, there's differential diagnosis. Not every eczema is atopic dermatitis. So it could be in other eczematous disorders like contact dermatitis, which we'll talk about, seborrheic dermatitis, dyshydrotic eczema, hand eczema, nummular dermatitis. These are common other causes of eczema. It could be psoriasis. Sometimes there's an overlap between psoriasis and eczema. It could be an infection, scabies, and the way you can tell if it's scabies is when you give oral corticosteroids, the itch actually gets worse. So if that's usually a telltale sign that you may be dealing with scabies. And then you have some unusual disorders. These are more rare. In our field, we think about immune deficiency disorders, especially if the child has severe eczema very early onset, before age 1. It could be photosensitivity. And in an adult, and this is an important point, if you have an adult with late onset atopic dermatitis, and if the rash doesn't get better with your usual treatments, then you need to think about cutaneous T-cell lymphoma. So this is something you don't want to miss. As a general rule, I always say, if the rash doesn't get better with my treatment, I send the patient to the dermatologist for a skin biopsy, because you want to make sure that you're not missing anything. Now, in terms of investigation, so as an allergist, most of the time with atopic dermatitis, no labs are necessary for most patients, but you may want to do allergy testing, especially for if you have respiratory allergies. So if the child has allergic rhinitis, if the child has asthma, you want to test for respiratory allergens, which are relevant to your climate. And then foods, this is very controversial. A lot of times these kids will get tested for foods, but I'll share with you, please do not routinely test, because when you have someone with eczema, especially a child, you'll have a lot of false positives, up to 60% false positives. And so just because a test for food is positive doesn't mean that the child necessarily has to avoid the food. And so more on that. So about 50% of children with atopic dermatitis will have positive skin tests or blood tests to one or more foods, especially milk, egg, wheat, peanut. Which means the child is sensitized, but that does not mean it is clinically relevant in most cases. In fact, there was a recent meta-analysis that showed that dietary elimination of these foods has not shown to be beneficial in most cases. And so, and moreover, it can lead to, if you restrict, the food intake in a toddler, this can cause issues with weight gain, growth, development, etc. And so the only time you want to avoid a food is if the child has had anaphylaxis to the food. Otherwise, don't worry about the positive skin test. And even more importantly, don't even bother getting food tests blindly in the first place, because it can be very confusing for the clinician. It can be even more confusing for the parent. All right, so we'll talk about management of atopic dermatitis. So, first, before we talk about that, what are the goals of therapy? So as much as possible, you want to achieve normal skin. So you want complete skin clearance, no lesions. You want to reduce the itch, which will also help us sleep. You want to improve quality of life. A lot of these children, are especially adolescents, it can be embarrassing, socially embarrassing if they're covered with eczema, especially in the visible areas like their face. So you want to improve their quality of life. You want to maintain normal activities of daily living, minimize or maximize disease-free periods, prevent infections like staph, and you want to minimize side effects, because some of the side effects of these therapies are not completely benign. Long-term topical corticosteroid use can thin the skin. It can cause acne. It can cause it can cause stria. So you want to be a little bit careful about overusing topical corticosteroids. All right, so in terms of management, this is based on a European guideline that was released in 2022. We'll talk a little bit about, I won't go over the entire thing, but we'll talk about some basic things. So this is kind of what I call first line therapy. This is baseline. This is for irrespective of the degree of eczema, whether it's mild, moderate, or severe. You want to do emollients, you want to avoid irritants, you want to hydrate the skin. And then we'll talk about, mild and moderate eczema, where basically the cornerstone is topical corticosteroids and topical calcineurin inhibitors. And then we'll talk a little bit about systemic therapies for this more severe eczema. All right, so first of all, let's start out with the basic things. So this is the most important thing, emollients. Okay, so emollients, they help restore the normal epidermal barrier. Ointments are actually better than lotions because emollients tend to evaporate less easily because there's less water content. Okay, so try to use an emollient if possible, and use the emollient generously. There's no danger from excess use. Okay, so as much as you can, cover the child head to toe. Bathing is actually helpful. Oftentimes we hear, don't bathe the child. Actually, that's not true. Bathing is important. Water is helpful for hydration. It is the soaps and detergents that dry out the skin, not the water. And in fact, I would say combine the two. So what you do is you bathe the child, and then as soon as the child comes out of the bathtub, don't dry the skin. Slap on the emollient immediately afterwards while the skin is wet, what we call the soak and seal method. This really helps trap the moisture. All right, so these are my bathing recommendations. So you want to use lukewarm water as opposed to cold water or hot water. Baths are better than showers because it allows more contact with the water, right? So bathe the child as often as long as they tolerate. And when you do use, try to use non-soap cleansers if possible that are neutral to low pH, that are fragrance-free. Because those are less likely to irritate the skin. And you really don't need anything extra. Some of the additives like oatmeals, you can use if needed, but there are no good studies that have shown that they're superior than emollients alone. So, make things simple for the parents and make things, economical. You don't want to spend a lot of money on fancy things when there's no good evidence to support it. All right, second thing, avoid triggers. So these are irritants like soaps, detergents, sanitizers, perfumes. Okay, so these are contact irritants. And then you also have contact allergens, especially in a child with eczema. Oftentimes they can be sensitized to metals like nickel. They can be sensitized to fragrances, antibiotics like neomycin, and preservatives. Preservatives are in a lot of the topical ointments that use, especially propylene glycol. It's a common vehicle. And you can also become sensitized to the topical corticosteroid itself. In fact, almost 13% of patients with atopic dermatitis, over time, they become sensitized to the topical corticosteroids. So when you have someone with AD not getting better, consider patch testing. And then skin infections. Because the barrier is disrupted, oftentimes these children will get infected with staph, strep, herpes simplex, molluscum, the herpes virus, as well as yeast, especially the Malassezia furfur. And so when you do see an infection, you need to treat it appropriately. Other things that can aggravate eczema, occlusive fabrics. So you want to use a loose-fitting cotton whenever possible. Environment allergens, we'll talk about that. Sweating, dry and cold environment, hot and humid environment, air pollution, and stress. And a lot of these children, in fact, are under a lot of stress, psychological stress. And so that is also important to address because stress itself can increase the itching and cause and also disrupt the sleep. And as I mentioned before, there is no evidence that food avoidance is helpful in reducing AD severity or preventing flares. Only time you want to avoid a food is if it causes anaphylaxis. Now, one of the things you can do, especially if your patient has frequent staph infections, is to do what's called bleach baths. So these are bleach baths essentially help reduce staph colonization. And this is a recipe that we use, half cup of bleach in a 40-gallon or 151-liter bathtub filled with warm water. Okay, so what you do is you soak from the neck down, or you can just soak the affected areas for about 10 minutes, then come out, gently pat dry with a towel, and then apply the moisturizer. So the bleach itself, or the alternative would be just having them swim. So the chlorine, can help reduce staph colonization. So this is something that you would do about once a week. All right, now in terms of so these are the basic things right here that you should do all the time, irrespective of the degree of severity. And now let's start out with the first-line agents. So first-line agents for atopic dermatitis is topical corticosteroids. You have, as you well know, you have low potency steroids, medium potency to high potency, and ultra high potency. And these are the various classes. So low potency would be, groups 5 to 7. So hydrocortisone, desonide, fluocinolone, and these can be done twice daily for 2 to 4 weeks. And these can also be put on the face because they're low potency. It really won't thin the skin too much. It won't cause scarring. But you want to just, after 4 weeks, you want to stop and give the skin a break. Medium potency would be things like triamcinolone, 0.1%. And these, again, can be used up to 2 weeks at a time, but then you want to switch to a lower potency. And these you really don't want to put on the face or in the genital area or in the axilla because it can cause thinning of the skin. It can also cause systemic absorption. And then over here you have the ultra high potency corticosteroids, such as flubenazole. And this you really don't want to use more than 1 to 2 weeks. And it can never be put on the face or any of the skin folds because it is very high potency. So this is kind of the general schematic of how to treat atopic dermatitis. Depending on the degree of severity, you can go to some of the higher potencies, but again, it's limited, and you just spot treat. A couple of things about topical corticosteroids. So again, the potent ones should never be used, on mucous membranes, face, eyelids, genitalia, intertriginous areas. You only use twice daily until rash resolves, and then you can stop. However, you can use if you're really having trouble, if you have frequent outbreaks, then maybe you can proactively use it intermittently 2 to 3 times a week, but only in never in the steroid sensitive areas. And the reason for that is because there definitely are side effects. So local side effects would be skin atrophy, which is fairly common, periorbital dermatitis, rosacea. It can actually flare up acne. It can cause stria, and it can actually cause odor contact dermatitis. You can become sensitized to the topical corticosteroid itself. And then you can have systemic toxicities. So depending on the skin thickness, if the skin is thin already, and you apply the topical corticosteroid, it will increase absorption systemically. And this also depends on duration of use and steroid potency. And in infants and small children, you can actually cause adrenal suppression if you overuse topical corticosteroids. You really have to be a little bit careful. How much to apply? So this is a chart that I always, I don't have a very good memory, so I just give this to my patients, to the parents. So depending on the age of the child, and depending on the region, This is how much you should be applying. This is called a fingertip unit. So you just put the ointment, from the it's basically one tip. So this is an adult fingertip unit, and this tells you how much you can use. So depending on the age of the child, for example, if it's an infant, then you can put maximum, one fingertip unit in the front, 1.5 fingertip unit in the back. All right, now, so what, because topical corticosteroids do have side effects, there is an alternative, which are calcium inhibitors. Examples are pimecrolimus, tacrolimus, which comes in two strengths, 0.03% and 0.1%. And how these work is they block production of pro-inflammatory cytokines and other inflammatory mediators. So it's not a steroid, so it's steroid sparing. And so some of the advantages of using a TCI is, because it's not a steroid, it can be used on the face, it can be used on the skin, it can be used on the skin folds, genital area, other steroid sensitive areas. It does not result in atrophy of the skin. It does not increase the risk of skin infections, and in general, it reduces the topical corticosteroid burden. Disadvantages is more expensive, obviously. But if you can use it, definitely would encourage you to use it. It can also be used proactively 2 to 3 times a week in preventing recurrence. Only side effect is it can sting and burn, but that is primarily if you use it on acutely inflamed lesions. Usually the sting and burning go away once the skin heals up. Now, in theory, there is a risk. There's a box warning for malignancy. This is based on oral use of calcium inhibitors, such as cyclosporin, oral tacrolimus. But they've done many studies since the TCIs have come out, and there is no increased risk of cancer. So it's important, even though these still have box warnings on them, important to reassure the parent that these are safe and can be used long term. Now, treatments that you want to avoid if possible. Systemic steroids, especially in children. You really want to avoid systemic steroids because of its growth stunting, but also because it can cause rebound. So when you give steroids orally, yes, of course, the eczema gets better, but then once you stop, it causes a rebound, so you're basically stuck in a pattern. And certainly steroids do have both short-term and long-term side effects. And especially in children, you want to be extra careful because it can cause HB axis suppression. Another category that I would caution using is topical antihistamines, because this can actually cause sensitization and can cause contact dermatitis. So I would not use topical antihistamines. I would also stay away from sedating antihistamines. Now, if you do use sedating antihistamines, only use short term. If the child is having trouble sleeping, you can use that at bedtime, but don't use it during the day because it can cause cognitive impairment. It can affect school performance. Also, do not overuse systemic antibiotics because of risk of microbial resistance. If you do need to use antibiotics, preferably use topical antibiotics and only use in the areas where you see an infection. If you overuse topical antibiotics, you can develop sensitivity, and this will result in contact dermatitis. One easy thing, this is one trick I often will use. This is called wet wrap therapy, which is basically you take a wet clothing. You take a coat, you take any clothing item that is cotton-based, or you can use a gauze and basically just wet it and then put it on the skin and leave it on for a few hours. So you can use any item, wet tube sock, wet pajama, gauze. If you want, you can put a dry layer on top of it. And this really helps because now, your skin is wet for the next few hours, and this helps restore the normal epidermal barrier. So this is a very, very effective technique to help restore the barrier. Now, what happens when these therapies don't work? So now you're talking about severe eczema. This is where systemic therapies can come into play. There are a variety of systemic therapies, including biologics such as dupilumab. But I think those are fairly expensive. They may not be available depending on where you practice. But one thing that is relatively cheap and very effective is cyclosporin. So in fact, cyclosporin is, I would say, the preferred immunosuppressant. Basically, it's a calcium inhibitor, but it's an oral calcium inhibitor that has strong anti-T cell activity. It can, this is the dose, so 3 milligrams per kilo per day, and use it for about 6 weeks and then taper. It is well studied in children over 12. In children under 12, long-term safety data are lacking, but I still use it. But you do have to monitor for side effects. So potential side effects include nephrotoxicity, elevated blood pressure, hypertrichosis, headache, gum hyperplasia, a little bit more risk of non-melanoma skin cancer, and a little bit increased risk for infections in general. But as long as you monitor the patient, this really works well and actually has less side effects than oral steroids. The monitoring includes, checking blood pressure, making sure it's normal, making sure the kidney function is normal. So check it baseline, and then every 2 weeks for three months, and then monthly. Steroids, again, oral steroids, yes, they're effective, can be used short term, but you really want to avoid too many rounds of oral steroids because of their side effects. And then as allergists, we do have another option, which is allergen immunotherapy, especially in your dust mite sensitized patients. By getting rid of the dust mite sensitivity, it certainly can help the eczema, but these are more long-term treatments. It takes about 9 to 12 months before you see any positive results. All right, so we'll switch gears now. We'll talk about urticaria. I'm sure many of you in this, many of you in the audience have had urticaria at some point in your life. In fact, about 1/4 of the population, 25% of the population at some point will experience hives or angioedema or both. Most of the time it's limited, self-limited, they go away. Unfortunately, about 1% will have what we call chronic hives. And this is where it's a little bit more challenging. Now, what causes hives? It's really the mast cell and the basophil. We'll talk about that. And if it's self-limited, that's great. But if it's not self-limited, then it can have a severe impact on quality of life, which oftentimes is underappreciated. All right, so what is urticaria? So urticaria is circumscribed, raised. So it's a raised rash, erythematous rash associated with edema. The hallmarks are itchy, so it's pruritic, it's symmetric, they have pale centers, and if you push on the lesion, they usually blanch. They can vary in size and shape. And they last less than 24 hours. So if the urticaria lasts more than 24 hours, then you have to be a little bit suspicious. Urticaria does not cause fever, so the red flags would be fever, does not leave a bruise. There should not be any petechia purpura. There should not be any blisters. There should not be any joint pain. So these are all red flags, where if you see them, you really need to do further investigations. And then what is angioedema? Well, angioedema is well-demarcated edema of the deep layers of the dermis and subcutaneous tissue. Unlike regular edema, angioedema is non-pitting. It's involved in non-dependent areas. Face, lips, extremities, genitalia, and oftentimes with chronic urticaria, you can have angioedema 40% of the time. Now, if you have isolated angioedema without urticaria, and if it doesn't respond to antihistamines, corticosteroids, then that is the only time that you would think about bradykinin-mediated angioedema, i.e., ACE inhibitor use or hereditary angioedema. The vast majority, 99% plus of your angioedema is mast cell mediated, and you would treat it just like you would urticaria. All right, so how do you categorize urticaria? There's acute and there's chronic. Acute is less than 6 weeks. It can occur at any age, usually due to infections, foods, drugs, insects, latex, NSAIDs. And then chronic is when it's recurrent or more than 6 weeks. This is non-IG mediated. There's no role for allergy testing. And we'll talk a little bit more about that. And then again, if you have isolated, if you just have angioedema without urticaria, but if it responds to antihistamines, then you would just treat similar to how you would treat chronic urticaria. All right, so here's a schema. Less than 6 weeks is acute, recurrent or more than 6 weeks is chronic, and within chronic you have chronic spontaneous urticaria, where the reason is not known, and then you have inducible urticaria, where it's usually due to physical trigger. What causes urticaria? Well, the effector cells is basically the mast cell and the basophil, but you have other cells that can also participate, eosinophils, B cells, T cells. What happens when mast cells degranulate? Well, they release histamine. So, you know, you have a lot of histamine floating around. They also release leukotrienes, prostaglandins, platelet activating factor, pro-inflammatory cytokines, and other vasoactive factors. And that's why you get angioedema. And mast cells can be activated by multiple triggers. This is a mast cell. And obviously allergens can trigger mast cells, but you have a variety of other factors, including C5a receptors, which is a sign of activated complement, proteases, TLR receptors, toll-like receptors. So you have various other mechanisms besides IgE that can activate mast cells. So let's talk about first acute urticaria. So acute urticaria, very common, 25% of people will get acute urticaria. The good news is that most, 90% will respond to antihistamines alone, only 10% need steroids. So what are the common causes of acute urticaria? Well, number one is infections, especially in children. This could be upper respiratory tract infection, urinary tract, it could be parasitic infections. And most of the time, it is due to activation of the immune system, which results in immune complex formations. Complement is activated. You have C5a that is released, and as you know, as you can see, C5a mast cells have a receptor for C5a. So whenever complement is activated, it can cause urticaria. So a number of viruses can cause it, including coronavirus. A number of bacteria can cause urticaria, as well as a number of parasites. So this is probably the most common cause of acute urticaria. Second, foods. So now if it's a food allergy, typically occurs within 30 minutes of ingestion. So that means you eat the food and immediately within 30 minutes get the urticaria, angioedema, typically milk, egg, peanut, tree nuts, soy, wheat. Food additives and spices are very rarely implicated. And we see these food allergies more commonly in children with history of atopic dermatitis. Another common cause would be insects. So you have Hymenoptera, like bees, wasps, hornets, fire ants, which can not only cause urticaria, but also anaphylaxis. You have bites of mosquitoes, fleas, bug bites, bed bugs. Typically, they will cause papular urticaria, which basically are papules. This is more common in children. And you can also get chronic, if the child keeps picking on these lesions, you know, they can reactivate older lesions. And this is, again, this is what we call papular urticaria. This is usually a sign of insect bite or insect sting. Drugs can cause urticaria as well. You have IG-mediated urticaria, which can also cause anaphylaxis. This is when you take a drug and within 1 hour you have a reaction. So think about the beta-lactams, so penicillin, cephalosporin, and also NSAIDs, but not aspirin. Aspirin has not been shown to be IG-mediated, but NSAIDs certainly can. More commonly, you'll have non-IG-mediated reactions where the drug itself will directly activate the mast cells. So typically narcotics will do this, muscle relaxants will do this, radiocontrast media, vancomycin, and NSAIDs. And typically this is dose dependent. It's also infusion related, rate related. So if you slow down, for example, if you slow down the infusion rate of vancomycin, less likely to have urticaria. How do you test for this? Well, that's a whole another topic, but basically, unfortunately, there's only a very small number of drugs for which we have a validated test looking for Ig-mediated reactions, penicillin, cephalosporin, local anesthetics, neuromuscular blockers. Most drugs, there is no good test, and so you basically just end up doing drug challenges in the office. And then contactants. So contactants is when wherever the skin is directly in contact with the inciting agent, you'll have hives. So this could be a lot as animal saliva. So let's say the dog licks you or the cat licks you, you'll develop hives just in those areas. It could be a plant product or resin. It could be raw fruit or vegetables. It could be raw seafood. So for example, shrimp, if you're manipulating shrimp, prawn, lobster, you'll get hives just where the food touches you. Detergent, soaps, lotions are unlikely to cause urticaria. They're more likely to cause contact dermatitis. So what is the approach for the allergist? Generally for acute urticaria, routine investigations are not done just because of the short duration and self-limiting nature of acute urticaria. The only exception is if you are highly suspect an Ig-mediated reaction, such as a food, for example, then you can do selective skin testing or selective allergen-specific Ig blood testing, but only due to the suspected culprits. Don't make the mistake of doing an entire panel, because again, with foods especially, you'll have a lot of false positives, and then it'll be very difficult to sort out what is real and what is a false positive. So only do limited number of tests if you suspect a true Ig-mediated reaction. Now, switching gears, chronic urticaria is either urticaria or angioedema lasting more than 6 weeks, or that is recurrent. You have two varieties. You have chronic inducible urticaria, which is urticaria triggered by physical stimulus. That's about 25% of cases. And then the rest, what we call chronic spontaneous urticaria, where we don't know what the reason is. It's not due to physical stimulus. This is more common in adults compared to children, more common in women. And what I want to point out is it's a chronic disease. Its average duration is 2 to 5 years. So this is not something that will go away by itself. It can last several years. In terms of chronic inducible urticaria, again, the good news is that most of the time, except for pressure urticaria, most of the time, just antihistamines alone will take care of it. You have a variety of inducible forms of chronic urticaria. The most common ones are dermatographia, which many of you, I'm sure, have seen, where you basically just stroke the skin with a tongue blade, and the areas where you stroke the skin, it welts up. That's very common. About 3% of the population has this. Cold urticaria, where areas exposed to cold can cause urticaria. Also very common. You have cholinergic urticaria, where elevation of the body temperature. So, for example, when the patient sweats, when the patient exercises and sweats, they'll get hives, or when they're passively, when you heat the skin, for example, in warm water, they'll hive up. So these are fairly common, and then these are the less common. I won't get into the details, but basically, most of these can be treated just with antihistamine therapies alone. And then you have the more challenging case, which is chronic spontaneous urticaria, where only at best 50% will respond to antihistamines. And also, a lot of these patients with chronic spontaneous urticaria will also develop angioedema. Now, in this population, you do have some aggravating factors. So sometimes these patients can have physical factors as well that aggravate their hives: heat, cold, sweat, friction. Also, NSAIDs, about 4% of the time, if you have someone with chronic hives, if they take NSAID, their hives can get worse. So you want to minimize NSAID use. Stress, either physical stress or psychological stress, can also contribute. And then things like spicy foods and alcohol, especially alcohol. Alcohol can degranulate mast cells, so that can also aggravate hives. And so you want to be careful and tell them to minimize alcohol use. So in the case of chronic urticaria, again, routine labs are not recommended, assuming that the patient has no red flags. History and physical exam are unremarkable. However, that being said, you may do a limited workup. So if you do want to get labs, I would get CBC with differential, I would get sed rate CRP, and I would get TSH. Those are the three things I would get. If on your CBC you see a high eosinophil count, then maybe do a workup for parasitic infection. Get stools, ONP ×3 on the stools. If the sed rate and CRP are quite high, then look for systemic diseases, autoimmune disease, rheumatological diseases, infections, even cancer. And if the TSH is abnormal, then check for either hyperthyroidism or hypothyroidism. When to get a skin biopsy? Well, if there are red flags. So if the urticarial lesions last longer than 24 hours, if they're painful, if they have accompanying petechia or purpura, or if they leave a bruise, please send these patients to your dermatology colleague for a biopsy. Or if you have a very high sed rate, or if you have systemic symptoms like arthralgias, fever, then this could be vasculitis. So you want to, these are the cases where you would send to your dermatology colleagues for skin biopsy. How do you manage urticaria? This is based on international guidelines, which were just updated 2 years ago. So basically, first line is second generation non-sedating H1 antihistamine. You start out with a standard dose, whatever the dose is, depending on whether it's a child, adolescent, or adult. But very quickly, you want to increase the dose up to 4 times the dose. Okay. So, for example, loratadine 20 milligrams twice daily, or cetirizine 20 milligrams twice daily, or fexofenadine 360 milligrams twice daily. So 4 times the dose. Then, if that alone is insufficient, and as I mentioned with chronic urticaria, 50% of time, just antihistamines alone will not suffice. Then you add on either omalizumab, or if omalizumab is not feasible, you add on cyclosporin. All right, so we'll talk about, so second generation antihistamines, these are really first line treatments. These are some examples: bilastine, cetirizine, desloratadine, fexofenadine, levocetirizine, loratadine. Again, 4 times the dose. And there's no need to combine different antihistamines. Just pick whichever one the patient likes, just stick to it, but do 4 times the normal dose. And, we really don't, nowadays, we really shy away from using first generation sedating antihistamines because we know that these can cause, it can cause poor REM sleep, it can cause poor cognition. And now we know that even that long-term first generation H1 antihistamines can actually increase risk for dementia. So H1 antihistamines, try not to use. If you're going to, I would favor second generation H1 antihistamines. The other thing I also want to point out is, unlike in the past, we don't now recommend H2 blockers like ranitidine, famotidine. Unlike in the past, where we used to think, okay, maybe they're helpful, but subsequent studies have shown that adding H2 blockers don't really help much. Also, montelukast doesn't help much either. And we also gone away from using sedating tricyclic antidepressants like doxepin, just because of its cognitive impairment. So just H1, second generation H1 antihistamines, 4 times dose. All right, so what to do if that alone doesn't work? Well, here, if you can afford it, if the patient can afford it, you can give omalizumab. Omalizumab is, for those of you who don't know, it's a humanized monoclonal antibody against IgE. So it binds free Ig in the serum. It is approved for the treatment of chronic urticaria down to age 12. So these are patients who remain symptomatic despite 4 times H1 antihistamine therapy. The way it works is it binds serum IgE, which helps reduce free serum IgE. And it turns out that the mast cells themselves have Ig receptors on them, and they're in direct proportion to free serum IgE levels. So by reducing free IgE levels in the serum, you downregulate the number of Ig receptors on your mast cells. So therefore, you increase the threshold for mast cell degranulation. So by giving omalizumab, you're less likely to cause mast cell degranulation. So that is the mechanism of action. The dose is 300 milligrams every 4 weeks subcutaneously. This is independent of your serum IgE level, independent of your body weight. Couple of caveats, however, the first 3 doses have to be given in the office and secondly, patients have to carry an epinephrine autoinjector because there's a small risk of anaphylaxis, 0.2%. Other disadvantages, it's an expensive drug, so this is certainly not for everyone. Again, the dose is 300 milligrams every 4 weeks. There are not everyone will respond to that dose. Only 60% will be completely high-free with that dose. So sometimes you may need to increase the dose. You can increase, from 300 every 4 weeks. You can increase it, to a higher dose, or you can use a shorter interval. So up to 600 milligrams every 2 weeks can be used. Although the more Xolair you use, the more expensive it can become. Here's an example. So this is the pivotal study done in, this is a 11-year-old study. And basically what it shows is, this is looking at the itch severity in patients with chronic urticaria. Up here you have placebo, down here you have omalizumab 300 milligrams. And you can see that fairly quickly, within a few weeks, these patients, their itch score goes down. But you all can see that when you stop Xolair, so in this case, patients were given only 3 doses of Xolair, here, here, and here. Once you stop omalizumab, however, you can see that within a few weeks, things go back to normal. Things revert back to normal. So omalizumab certainly is not a cure. It's very important that patients understand that once you discontinue omalizumab, things are going to return. This is looking at the number of highs. And again, you can see omalizumab at the 300 milligram dose does certainly better than placebo. But again, once you stop the drug, within a few weeks, things go back to normal. So very important that patients understand that this is not a cure. Once you stop the drug, things may revert back. So as an alternative, and this is where I would encourage you, instead of omalizumab, maybe consider cyclosporin. So cyclosporin, as I mentioned, is a calcium inhibitor. It blocks calcium-dependent release of histamine, leukotrienes, other mast cell mediators. The advantage of cyclosporin is rapid onset of action. It has a degree of efficacy comparable to systemic corticosteroids, and this can actually induce remission. So typically within 9 months, you can actually achieve remission. Potential side effects, however, it can cause hypertension, it can cause renal insufficiency, it can cause hirsutism, gingival hyperplasia. And so this is something you want to avoid in your patients with chronic kidney disease, your patients who have poorly controlled hypertension. The dose is similar to the dose with atopic dermatitis. So it's between 3 to 5 milligrams per kilo per day. You want to monitor blood pressure, review, and creatinine. You also want to make sure that they're not taking any other medications that have strong P450 interactions like statin, systemic antifungals. Typically, once the highs are well controlled for 3 months, you taper off. In most cases, 6 to 9 months treatment is adequate. Systemic corticosteroids, if you're going to only use short term. Don't use long term because of side effects. Also realize that when you give steroids systemically and you stop, oftentimes you get rebound. So this is a common problem. And so steroids are discouraged. All right, the last thing, I only have 5 minutes left. So the last thing I want to talk about is contact dermatitis. Contact dermatitis affects about 5% of general population. This is caused by direct contact with an exogenous agent that elicits inflammatory response. So there are two varieties of contact dermatitis. You have acute and you have chronic. Acute will cause pruritic erythematous rashes with papules, vesicles, swelling, crusting. So here's an example of acute contact dermatitis. Whereas chronic, you'll have erythema, lichenification changes, scaling. And then within contact dermatitis, you have two varieties, irritant, which is about 8%, and then allergic, which is about 20%. So irritant is a non-immunologic inflammatory response to a substance that results in direct skin damage. How you can tell is irritant contact dermatitis, only the areas of skin that are in direct contact with the irritant will cause a rash. Whereas allergic contact dermatitis, this is a delayed rash. This is a T-cell rash, type 4 hypersensitivity reaction that occurs in an individual that is already sensitized to the allergen. For example, nickel. And if you're for example, if you're sensitized to nickel and then on re-exposure to that allergen, you will have allergen-specific T cells that migrate to the skin, which will cause an inflammatory reaction. What is unique about allergic contact dermatitis is that you may get the rash not only in the area where you're in contact with the allergen, such as nickel, but you may get rashes other places because you can transfer the allergen to other sites. Commonly, for example, hands, you can transfer the allergen from the hands to the face. And so when you see distribution of the hands and face, again, you really need to be thinking about allergic contact dermatitis. These are common irritants that can cause irritant contact dermatitis. You have chemical irritants like water, wet work. So this is where you're wearing inclusive gloves, frequent hand washing. It can cause a chemical irritation. Detergents, surfactants, solvents, oxidizing agents, acid, alkali. These are all chemical irritants that can cause irritant contact dermatitis. You also have physical irritants like working with metal tools, woods, fiberglass, plant parts like thorns, spines, sharp-edged leaves, paper, dust, soil. And physical irritants can actually act synergistically with chemical irritants such as detergents or water to cause even more disruption of the skin barrier. So it's a 1-2 punch. And then these are common contact allergens. So nickel is a good example, balsam of Peru, which is a fragrance, antibiotics like neomycin. You have accelerators, rubber accelerators like cover mix. Many plants, the typical plant is poison ivy, which will cause allergic contact dermatitis, but you have other plants as well. And then topical corticosteroids can also cause contact dermatitis in a person who's had repeated courses of topical corticosteroids. So how do you make a diagnosis of allergic contact dermatitis? This is what we call patch testing. This is a standard, gold standard. So it involves the application of test allergens under occlusion onto the upper back for 2 days. So you put the suspected allergen, you apply standard amount to either aluminum or a synthetic chamber called thin chamber, and you mount that on a non-occlusive tape strip. That's how you do the standard patch testing. There's also a test more expensive called True Test, which is rapid use epicutaneous test, which contains 35 preloaded allergens and one control, so you don't have to do these tests individually. You just put the patches on directly. Okay, so this is the standard test where you put, on the fin chambers, you put different drops, different allergens, and you tape this to the back, and in an area where you don't have a rash. This is the True Test, where it's basically 36 allergens already preloaded. So you don't have to mix anything. And then the patient wears this for 2 days. And then after 2 days, you remove the patches, you do a first reading after about 15 minutes. And then you have the patient come back either in 48 hours or 72 hours and for a second reading. And the reason you do 2 readings is sometimes you can get an irritant effect. So sometimes the allergen itself that you put can cause skin irritation. And so you may get a false positive on day 2, but by day 4, the irritant reaction will go away. Whereas if the reaction remains, and that is a true allergic reaction. Also, some of the allergens like nickel, topical corticosteroids, you may not see a reaction after 2 days, but you'll see a reaction after, after 4 days. And so that's why you do 2 different readings. And then once you've identified what the patient is sensitized to, then you need to educate them on how to practice avoidance. All right, so just to summarize, this is the last slide. Remember, the skin is one of the largest immunological organs of the body, and often a target for allergic disease. Remember that atopic dermatitis is first disease in atopic march. So if you intervene early, you may help arrest the progression of disease. Remember that contact dermatitis can coexist with atopic dermatitis due to disruption of the epidermal barrier. So if you have eczema that is not well controlled, consider patch testing. And then finally, remember that urticaria is self-limited in most cases, but chronic urticaria is chronic, can last 2 to 5 years, and 50% will not respond to antihistamine therapy alone. And so you may have to add omalizumab or cyclosporin. All right, so I will stop there. And I think we're going to.
Thank you, Doctor.
Yeah.
Thank you so much for the detailed and the informative session on the skin and allergy. I now request Dr. Balachandra BV, the Director, Bangalore MedTrain LLP, and acclaimed pediatrician, to give us the overview of the AASC Caribbean. Over to you, Doctor.
Yeah, thank you, Celestine. Am I audible?
Yes, Doctor.
Yeah. So I'll be sharing the screen. Is the screen visible?
Yes, it's visible. Yes.
Is the screen visible?
Yes, the screen is visible.
Okay. 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 So good morning, dear doctors and teachers and the support staff who are here. I'm going to talk on certain interesting development which is going to happen in the training program of allergy and asthma in AASC Caribbean. So I am Dr. B.V. Balachandra. I'm a consultant pediatrician and allergy asthma specialist. And I practice in Bangalore, India. And I work in Allergy Central Center of Excellence for Allergy and Manipal Hospital. And I have been thankful to God that I had an opportunity to train under Professor Dr. P.K. Vedanthan, Dr. Vinay Mehta, sir, and under the able guidance of Dr. P.K. Vedanthan, sir. We are able to start allergy asthma specialist course in India in 2001, and we have been successful in training about 546 allergy doctors in India from last 3.5 years. So now we want to bring in this allergy asthma training program to Caribbean countries. So basically, what is allergy asthma specialist course? So allergy asthma specialist course is a 9-month hybrid course on allergy and asthma. And this is a particular course which is completely the course is, the 9 months content is completely recorded, animated course wherein a rich learning experience is made while learning. And there's a lot of effort which has been made to make sure that the interaction with the faculty, the students are maintained, and the whole course is available on your software, on the LMS, on your mobile, on your laptop, on your iPad, anywhere. I'll be talking about more details subsequently. So now, question is, why is the need for allergy asthma training? Is there a need in Caribbean countries? I did some of the research studies, and I'm going to just put few highlights on that. This is an article released from BMJ 2012, which says that the prevalence of asthma varies from 17% in certain Caribbean countries to about 30% in Costa Rica. And about every fifth child in Jamaica has caught and reported wheeze or a self or a doctor diagnosed asthma. And the prevalence of allergic rhinitis, prevalence of hay fever and eczema among children is 24.5%, 25%, and 17.3%. That's a big number. That's almost like 1/4 of the children are having some kind of an allergy going on. There's another study which says that when a skin prick test was done among the subject population, about 50 to 81% of the subjects was tested as positive to one or other allergens, and there is a high prevalence of different kinds of an allergic diseases which is going on. That's a huge number. Even compared to the rest of the world, it's a huge number. So again, when we compare the standards of allergy training, let's take developed countries like Europe or USA, wherein there is about one allergy specialist for every 50 to 60,000 populations. And if that's the criteria which is being considered, then Caribbean countries, which has got a population about 44.8 million, needs about 897 allergy specialists. At present, what I've understood, okay, is there are very few allergy specialists who are trained in abroad or managing this huge population. And this also makes that there is a huge need for allergy specialists on this region. What is this allergy asthma specialist course, this Caribbean allergy asthma program? It's a 9-month course. As I told, it is a online course with a short contact session. These courses are available on your phone or on your laptop. It's a recorded animated content. Along with that, there is an 18 online Zoom contact sessions, and there are 3 days of personal contact sessions and 1 exit exam, which is important for certifying it. This course contains about 12 modules, about 34 chapters, and a self-assessment after each chapter. And there's also, along with the course, there is a textbook of allergy for clinician, which is the latest edition, and a small set of allergens are given for practice. And most importantly, a library of 90 plus, now it is about 110 case discussions are available, which the last 5 to 6 batches which is training has happened in India, those case discussions from the best faculty and the students' presentations are available to learn about the case discussions, the presentations, and the approach. Also, this course supports several documents which is required for your practice. It could be an allergy testing reporting form or an anaphylaxis or an action plan for asthma. So all the documents are supported, and there is a monthly course calendar which has been given so that you are well aware of what activity happens at what particular point of time. So though it is an online course, an extensive effort is made to maintain the interaction with the faculty and the students. and then weekly, on a regular basis, weekly twice or thrice, a WhatsApp poll, which contains several questions related to the subject, or it may be an aerobiology, it may be some kind of an allergy Q&A or an MCQs. So polls are run. And as I told you, the 18 online Zoom sessions, which involve several case discussions and Q&A sessions. Also, to make sure that the frequent assessment happens so that the sequential learning is appropriate. Every month there is an test which may need about 20 to 30 minutes for a learner to spend time to answer the questions. And this becomes a part of an academic performance sheet. And every month there is a reporting format is there so that every learner understands at what stage they are. And if anybody is lagging, there is a communication with the faculty is being made. And if required, faculty can discuss and help them to make sure that they are on the path of good learning. The personal contact session, which is a 3 days of in-person session, is required. The whole course is 9 months, which is an online, both recorded version as well as a Zoom version. But 3 days of in-person session is required to teach an most important hands-on skill. Very practical aspects are dealt there. All the theoretical aspects are covered online. So the course also demands a minimum of 5 skin prick test performance, because the whole intention of doing this course is to make sure that the learner practices allergy while doing the course itself, so that there is a continuity maintained even after completing the course. So there is one theory exams at the end of it, exit exam, and there is a practical exam. Practical exam means, though it is practical, it is done online, but it involves the assessment based on the practical aspects of that. The credibility of the course comes from the certifying body. So the AASC Caribbean program is certified by Bridgetown International University from Barbados, International Asthma Services, and MedTrain. This course is endorsed by American Academy of Allergy, Asthma, and Immunology and Center for Global Health, Colorado School of Public Health. So that's the credibility of the course. This course has been developed by the best national and international faculties from USA like Harvard University, University of Colorado, Singapore, National University of Health Singapore, and from India, several centers from India. This is a huge list of the faculty who have built the course. So I would name few of the faculties like Dr. P.K. Vedanthan sir, Dr. Vinay Mehta, Professor Harold Nelson, Dr. Murali, and many other doctors have put in their effort to build a very, very good content, a very, very good course. The faculty who will be responsible for having a regular connectivity with the learners are Dr. P.K. Vedanthan sir, Dr. Kandamaran Krishnamurthy sir, myself, and Dr. Narmada, who will be your academic coordinator as well as a faculty. We have a very excellent advisory board who are going to guide us of the regional requirement. Dr. Steve Cowrie, lecturer in child health, Dr. Kirik Douglas, Director Center of Biosecurity Studies, and Dr. Arifa Alauddin, pediatric nephrologist and from Royal College of Physicians and Surgeons with expertise in allergy. Dr. Jennifer M. Knight, Dr. Jennifer M. Knight, Professor of Pediatric Pulmonology and Clinical Research, Dr. Angela Jennings, HOD Pediatrics and Lead Consultant, and Dr. Dwan Alien, MICU Consultant and Pulmonologist. Please forgive me if my pronunciation is wrong. So these are the images which is showing that previously these kind of a programs conducted in India and how successful it has been. Starting from July 21st, 2021. This is the first batch, second batch, third batch, fourth batch, fifth batch, and the sixth batch is a currently ongoing batch with 120 students learning. I would like to share a small study which we had conducted among how our students are doing after their training, and this was presented in World Allergy Congress, which recently happened in 2023. We wanted to know the experience of learning on this mobile app. 98.9% felt it is good or very good. This was graded into 5 groups. Score of 5 was considered as very good, score of 4 as considered as good, 3 as an average, 4 as below, 2 as a below average, and 1 as poor. So 98.9% had good or very good experience in the learning on mobile app, and about 96.45% had a good or very good experience on Zoom session, and 87.2% had good and very good on the social media like a WhatsApp or a media to use learning. 3-day personal contact session, about 100% of them felt good or very good experience of learning. The impact of allergy asthma training program was looked into. So about 91% of them felt good or very good of level of confidence in practicing allergy after the training. 87.72% of our doctors are performing skin prick test, and 56.14% of them are practicing allergen immunotherapy. And the last question, and a very important question, what we assessed was, because most of the doctors were practicing pediatricians or ENT or otolaryngologists or pulmonologists or respiratory medicine or physicians, they did not have a complete time to dedicate and do any other course. So we asked them a question whether there is a need for hybrid-based allergy asthma training program, and 92.86% of them have mentioned that without an hybrid training program, they would have never done an allergy asthma, or they would have never upgraded their knowledge in allergy and asthma. So this is a course which will be launched in Caribbean countries. 21st of July is this course is going to go live. And I think the applications and the brochure is already released. I'm sure many of them would have received it. If not, you will be receiving it. And I'm sure that my team would be putting a link on the chat box where you can go directly to the course page. And 21st is where the course will actually start. So it's about the course. Thank you. Thanks for giving me this opportunity and sharing of what is being achieved in India. And hopefully we'll be able to do the same thing in the Caribbean islands. Thank you.
Thank you, Dr. Bala, for opening up such a wonderful opportunity for the Caribbean physicians. I now invite the national and the international faculty for the panel discussion. I request Dr. Angela, the head of departments, Queen Elizabeth Hospital, Dr. Crick, Director of Biosecurity, Barbados, University of West Indies, Dr. Steve, Lecturer in University of West Indies, Professor Jennifer, Madden, Sickle Cell Unit, Jamaica, Dr. Dawn, Pulmonology and Critical Care, Queen Elizabeth Hospital, Barbados, Dr. Arifa Khan, Guyana, and Professor Hariharan, Dean of University of West Indies, Trinidad, to join for the panel discussion. And I request Dr. Kandamaran sir to take over the panel discussion.
Hi, good morning again. Excellent talk by Professor P.K. Vishal and Dr. Vinay. And Vinay, it's been a long time to meet you. Good. How are you doing?
Good.
It's a very useful talk, and we see that allergy and asthma is increasing day by day. I see from the last 10 years to now. And in fact, I'm being in charge of pediatric ICU. I see number of admissions of asthma has been increased from 20 to 30%. This is the ICU admission I'm talking about, and there is a increase admissions in the ward. it's not only in Barbados, I mean, across the region. And I think the other regional faculty, I think Dr. Corey is here, and I'm not sure that the rest of the faculties are here because they say they will try to make it, but I don't think they are here. If you are there, please open up. Steve is here. Dr. Steve Corey is here.
Yes, I am.
Okay, good. And Prof. Hari is here. I mean, it will be an important tool for us for Professor Hari about the research moving forward because there is not much data about allergy and asthma. And I am looking for Arifa from Guyana. I'm not sure she's here now. And Dr. Angela Jennings said she will try to join us. She is running the asthma clinic in pediatrics. I don't think they are here. So, but still, we will continue. And Corey, what do you think the major cause of allergies in Trinidad?
Was that directed at me?
Yeah, Corey. Just
Oh,
give me a
sorry.
brief outlook about how's the allergy.
I would imagine that just like the rest of the world, the commonest cause of food allergies would be milk, eggs. I think wheat will be a common one as well. This would be my top three. I don't think we know enough of the prevalence and incidence of food allergies in children in Trinidad and Tobago. Dr. Julian Wheeler, who's not here, she worked in Tobago for a long time. She would have had a better idea about that, but there's no real true documented results, and that might be one of the things that we can look at. Allergy services in Trinidad are pretty non-existent. So I would imagine those would be the top 3 or 4, which would be reflective of. In terms of air allergens, that again has not been established, but the commonest air allergens we have would be grass pollen, tree pollen, and ragweed, which I just made a check, and actually we have none of those pollen for the next 3 days. Of course, Sahara dust, which is right now a huge problem. I suppose across the Caribbean, but more not including Trinidad. And in terms of the other allergies, I know Dr. Mehta mentioned atopic dermatitis, and certainly when I practiced in Trinidad in the 1990s, we did see quite a bit of eczema, and I would actually say that the incidence at that time was sort of reflective of the figures he quoted, but it was probably more common in the mid-childhood years than the early childhood years, which was a little bit strange.
Well, thank you, Gauri. I mean, I would get some feedback from the international faculty about the Sahara dust here, which is quite, I mean, for long years, the incidence has been most of the acute severe attacks of asthma comes in, and the parent says that it's because of Sahara dust straight away. Of course, that's one of the factor, but I want your feedback about how the Sahara dust, which is in other parts of the world, is it affected, or is it what are the preventive measures you guys doing? PKV sir.
Oh, okay. Sahara Desert, as the name indicates. Thank you, Dr. Kanda. I don't know a whole lot about it, but I know that this dust originates from the Sahara Desert, okay, as the name indicates. And actually, it has got certain positive things and negative things. This dust, which is actually travels in the atmosphere from along the Atlantic Ocean, it comes over and it facilitates the growth of the forests. So this is a natural phenomena. Natural phenomena always has certain reasons for it. It's a natural phenomena. So the nature, what it's doing is transporting the Sahara Desert, which has got the sand, dirt, and other microbes or whatever. I don't know the exact composition. It facilitates the growth of forests as well as greenery around. But at the same time, the particulate matter is what causing the human ailments, especially respiratory diseases, cardiovascular diseases. And since the Caribbean is on that wave where the sand comes, it sort of, I'm sure, it accumulates quite a bit in that area, as well as there are certain ways Caribbean authorities are measuring it. Actually, they have certain instrumentation they have installed right in Barbados. I don't know exactly where, but you can find out. But if they measure it, they know exactly how much dust is coming in, and it is a significant factor in the causation as well as exacerbation of respiratory diseases. And one thing that is amazing for me is the prevalence of allergy and asthma in Caribbean is extremely high. Something like 23% is what I read. It is probably one of the highest on the globe, I would say. You know, anything more than 20 is terribly bothersome. So there are some reasons that are peculiar in the Caribbeans, more than just dust mite and pollens. There could be some additional elements that could be causing some of these situation. And I really would appreciate the local experts there to comment on it. And you also have that that mold that grows under the ocean that could also be playing that role I mentioned to you. I forget the name of the disease, Sanmu's disease or something like that. I want the local experts to comment on it.
And we in the Caribbean, we have that sugarcane, this thing. So when they burn at the end of the cultivation, so that triggers as well. So I just want to give what's your thought about that sugarcane after the
It is a very, very major source of particulate matter. We see this in India a lot. You see, they say Delhi is one of the most polluted cities in the world, but the pollution is not originating from Delhi. It is originating from the neighboring state, where the sugarcane, fields are, because for agriculture they need to revamp, renew the growth, whatever. They put this on the artificial fires. They actually, all the dried up thing, the vegetation goes on this artificial fire, and it is like any other forest fires. All this particulate matter due to the wind enters the Delhi area and pollutes it incredibly. Okay, because even if you just take Delhi alone, I have been there several times. It is not too bad other times, because there is no usage of diesel fuel in the public vehicles there. It's all natural gas. And they have taken many, many measures to make sure that the fossil fuel usage is reduced in Delhi. But they end up having huge amounts of pollution because of this sugarcane dust, as you're burning, what you're mentioning, which is another issue in the Caribbean, I'm sure.
And with Dr. Kirk Douglas, he's not here actually. He's gone to Sydney to give a talk on climatic change. Apparently, we liaised with him, and then we setting up almost 9 to 10 antenna for the particular matter to measure. So it just recently been installed, and we are working on it now.
In Barbados? In
Barbados in
Western
each parish, yes. So we are looking into those particles, so that will help. I'm not sure whether the same system has been established in Trinidad or Guyana. What, Steve? What do you think, Dr. Steve?
In terms of what the reason for the increase in allergies?
No, for they measure the PM particulate matter to check for the pollution, how high the pollution in each area of Trinidad, each parish.
They do, but I don't know that they do it by parish per se, but they have looked at the PM that I think are less than 2.5 microns, if I remember correctly, but they do measure it.
Sure.
It is measured, sorry.
Good to know. So that will predict us, certain time and variation. And when say Sahara dust is coming in, so we'll get a clue that whether the impact is high or low or it's normal. I think that will give us where to go about it.
Just out of curiosity, what is the sensitization rate among your population for Aspergillus? Because I think that mold may be important in the development of asthma.
That's a
Especially, I
big.
think,
Thank you,
yeah,
Doctor. Big
Very good
gap
thought.
here in research in terms of documentation to study. That's why I asked Professor Hari to give a feedback about the research. We have to develop the research about allergy and asthma in the Caribbean. Recently, we had tried to get the information on food allergy with the Professor BK sir and the physicians. What is the knowledge about the food allergy and what are the sensitive things in among the physicians? And it's almost going to complete, so maybe it will be published shortly in Barbados. Prof. Hari sir, so you can suggest about the great gap, how to fill in this gap on the research about allergy and asthma in our region.
Yeah.
He's
I was
muted.
attending from the beginning, and it was great talk by Prof. Vedanthan and Professor Mehta. Very, very enlightening. You know, both of them, I know that they struggle to get the exact prevalence and incidence data from the Caribbean. I mean, I know that one of our retired professors, Michel Montail's study was quoted by Dr. Balachandra. It's old, the 1990s. I know of environmental microbiologists at the campus who go to the northeastern point, which we call as Toko, during the Sahara dust season, and then collect and also do some culture tests and the particulate matter test. As Steve said, particulate matter is being routinely analyzed, but the specific question was about aspergillus. I know Professor Ram Subhag, who is an environmental microbiologist, works on it, but I have to ask him whether he specifically looked for aspergillus. But I know that from all my OSH encounters, occupational safety health, the aspergillosis is a big issue. But the research for the prevalence of aspergillosis is still not very clear. So that's where the University of the West Indies will be able to help or even collaborate with the MedTrain, and if there are students who get interested in this course, and then they will be definitely be a factor, an impetus for doing such research, because unfortunately both the presenters had problem in collecting data from or published data from Caribbean, and they had to extrapolate Latin America and the United States. So I think this is a very good start. We do have the resources here. It's not that we don't have the resources, but probably we haven't seen the impetus because nobody knows the magnitude of it. As Steve said that from 1990s everybody um, encounters these patients, but nobody saw that there is a scientific need to document and see that there is a magnitude of this problem, and we need to actually do some research, get some evidence, and the resource should be allocated towards mitigating those risk factors. So I want to collaborate with the MedTrain and this program, and so we can actually, I can put Professor Ram Subhag, who is very much into this, and also our own Faculty of Medical Sciences microbiologist, so that we can get some good data. Most of them are doing hospital type of culture sensitivities and the resistance patterns and the metalloproteinases and all that, but no, there's not much work, especially with the environmental microbiology, collaborating with our specialists at the hospital. I think that is where the focus should go, and this is a very good trigger, and I think I will definitely collaborate with this. Thank you, Dr. Krishnamurthy.
Thank you.
Dr. Kanda, can I comment?
Yes, sir.
I think very well received Dr. Hariharan's comments, and I just want to share that whatever order of events these things can occur, we have a track record in India. Say, for example, in 1985, I go every year. In 1985, I saw several patients on consultations and all that. For follow-up, I could not find one allergy specialist in the whole of South India. You are talking like 300 million people right there in South India. I could not find one. Now I can find an allergy specialist every 10 miles on an average, 20 miles I can find. Okay. So the first thing to do is to elevate the knowledge base. Once you have knowledgeable people, then what happens is these studies actually start percolating in. They start getting interest. They start doing studies. We also provide the infrastructure. So I'm very proud to say we have about 2,500 specialists now in India. And we have produced at least 45 to 50 international publications in BMJ, Lancet, WHO. Every other week, there is something coming. So allergy, India is on the allergy map. The reason why I feel so positive about Caribbean is you are right beside a very big neighbor who is the world leader in allergy. Okay. So to get some assistance or from professional as well as technological help should not be a major issue. People are interested to know what's going on with the neighbors. So that is where IAS will definitely help in trying, along with the MedTrain, we are going to improve the knowledge level. And since we are US based, I can go ahead and help out in getting some technological help, some help in the research. And I feel this marriage between these three type of partners will definitely help the Caribbean situation.
I fully agree, Professor Vedanthan. I think that is the way to go. I mean, you nicely uh, put the evolution of how this happens, because
Yes.
there will be apathy as to start with. Yes, it's almost yeah, everybody gets allergy, right? So let's treat with whatever some CME, attend CME, and just do it. But as you rightly pointed out, only when there are people who are well trained and focuses towards that particular thing, the research will come. And I'm surprised that that you were able to list that the top notch journals of Lancet and BMJ we are able to publish from India. So I'm sure Caribbean will have lots of good material to be published. And so I think that is how we have to enhance the academic activity from the Caribbean. And I will work with Dr. Corey, who is in pediatrics. I know that he has a very hectic workload, but we can try and see how we can collaborate with the International Asthma Society, which you can help us, and we can actually make some protocols, research proposals, and start the ball rolling.
I think so. Like we have a sort of a small research team. And one thing that has resulted, doctor, is the rest of the world is now interested in India. Why is prevalence of food allergy so low in India? You have got all these adverse situations, but your food allergy is less than 1%. Why is this? So they want to know there is something in the environment or in the lifestyle or in the food intake or when the introduction of fermented food or whatever happens. So the interest is actually has been provoked by doing the Indian studies in the Western academia. They want, because the Western countries have very high, for example, Australia has 1,000 times more prevalence of food allergy compared to India. So they are interested to know what is happening. So I think this is a global phenomena. I hope all these efforts will have some fruitful ending. Thank you so much. I'm sorry I take more time. You are muted, Kanda.
I mean, that is a good collaboration to moving forward. I have my colleague from Jamaica, Dr. Catherine, if she can give some valid input what's happening in Jamaica. But of course, I'm not sure whether she is in here now. I can't see. But that's okay. But anyhow, I mean, there's a huge deficit in training and management and also in research. So I think we look forward that MedTrain with this collaboration, we take this course, and I would wish you all thank you so much. And you can always, there's a website to get in and log in and more information. We are there, assistants, all the information is in the website. So we can always contact us, and we'll end this. Professor PK, sir, anything you want to say? And Dr.
Anything I
Vinay.
want to add, just one more thing. Actually, I was very pleasantly surprised about a few weeks ago when the president of the American Academy of Allergy approached me and said, I was in India. I find there's a huge interest in allergy, and I found that the whole place is sort of, this allergy scenario, it has changed significantly. So we are interested to talk to you to see how Academy can help you. So we had like an online Zoom conference with the president of the American Academy of Allergy, along with a couple of faculty, and Dr. Vinay was also very, very instrumental in writing up a proposal now, which we have given it to the American Academy, how we can work together to make things better in India. And the same thing, the reason I'm mentioning that is the scenario is changing now. American Academy is not just interested only in America, it's global interest, because they also have introduced the third journal of Journal of Allergy. It's a global edition we have. Every month it comes, there's a global edition that's coming. And also online, they have a global edition too. So this is the best time for us to do something about the Caribbean, because Academy is also interested. They might be help us in many different ways, especially aerobiology and several simple studies where you may not have to worry about too much funding. You can do many good studies without too much funding, but you need some motivated people behind it. Human element is the key for it. It is not money. Human element, because a lot of studies we have done in India did not have much funding, but dedicated people who want to do something. Human element is the key. And that is why I find this course, MedTrain, and which we are trying to propose, will produce that human element.
Okay. Yes.
Thank you so much for the opportunity to share it with you.
Again, I thank everybody.
I don't know if Vinay has anything to say.
Yeah, no, I agree. I think this is going to be a collaborative effort. And I think the more people that you reach, especially, those who can see direct impact on their patients. So whether it's adult physicians, pediatric patients, if you can show that this has a direct impact on patient lives, quality of life, mortality, morbidity, then that will generate more interest. And I think, as we discussed this morning, we need, even the most basic epidemiology studies have to be done in the Caribbean. You can't extrapolate from US data. The population is very different. And so you need to do some foundational research first. And only from there can you generate hypotheses, which then you can prove or disprove. And I also think that I think aerobiology is an important factor in having, establishing, what is your local aerobiology is also very important, very fundamental in helping mitigate these respiratory issues. So I want to commend you for starting this program, and I wish you best of luck. And certainly I will, for my part, I will try to help out as much as I can.
Dr. Bala, Dr. Kanda, ask Bala and Jagdish to comment.
Yes. Dr. Bala, Dr. Jagdish.
Sir,
Guys, I can't hear you.
yes, sir, I'm here. I didn't get the question, sir.
No, I just any feedback from after this discussion. So just we're going to close this. So
Oh.
you can give some comments about it.
Why don't we say we will tell them to come online?
Yeah, I'm online. This
Oh,
is
okay.
Dr.
You have some final comments, Bala.
Oh, nothing, sir. I mean, I would say that this is a great forum and we have a great opportunity to expand the knowledge and what's been achieved in India with the experimented, and as well as we have a lot of learning on conducting last 6 batches, and each batch we have upgraded and took a feedback from the students and made sure that the course is made more apt for the learners. And the same thing we would like to see to that the doctors in Caribbean islands are being uh, given the best of the course, best of the knowledge, and then made all the opportunity available for starting their allergy asthma practice, doing the researches, and make sure that most of the data from the regional area comes out.
Thank you. Thank you, Dr. Bala.
you.
Excellent.
Thank you.
I think not all the islands doesn't have more specialists like a aerobiologist. So we might
Okay.
get from Professor PK Visar and Bala. So just letting you guys know. So we move forward for this course and an excellent initiative to start with. And I would like to thank each and individual, everybody, single person who attended this webinar, and excellent teamwork, Bala and backside of his team who worked very well in a short period and a short span. And I have to personally thank Professor B.K. Visar and Dr. Vinay, which has given a short notice to him as well. And he looked forward. He just came into the picture very quickly. Thank you. Thank you so much. Thank you once and all. And we look forward to you and the attendees. Thank you so much. And I will look for any information regarding the online hybrid course about the allergy and asthma. It's there in website, but anytime you can contact me, who has my email and other information. Mr. Anudeep is information, and MedTrain information is there on the website. Please pop in your email or any doubts, just facilitate or local. You can make a call or WhatsApp call. We are available to explain about this course further. All right. Thank you. Thank you once again.
Thank you.
Thank you. Good night.